Good morning. My name is Michael Bednar. I'm with the Center for Fiscal Equity, and these are comments for the record for the Committee of Finance, behavioral health care when Americans need it, ensuring parity, and care integration. Parity is a worthy and enduring goal that is more aspirational than achievable. Behavioral health wards and rehabs are run very differently than the standard hospital floor. You simply cannot treat patients who may be having suicidal ideation in settings with electrical cords and IV tubes. There are also security reasons. Behavioral health patients have different medication issues and sometimes must be court ordered to take meds if they are out of control. We, since I've been a patient more than once, may have self-control issues, although I present pretty well, so I didn't, but I see it. Leaving AMA against medical advice from a standard hospital is unlikely and is usually only a danger to the patients themselves. Behavioral health patients are held on a somewhat involuntary basis. When you get in there, you have to agree to go for 5 days unless they let you out earlier. And they can court order you to stay. Behavioral health patients held in the criminal justice system cannot leave at all. They're still locked up. Please see the attached comments from last year before this committee and the Ways and Means Committee from February, where mental health care in the criminal justice system and the need to hold patients longer and deal with either alcoholic relapse or medication noncompliance. Behavioral health is especially like no other. Prescribing psychiatric meds takes training and is an art rather than a science. In fact, it's almost malpractice to let the GPs do it. Not so much for the for OBs, but you do need comprehensive care, and I think coordinated care must include a psychiatrist, which is one of the topics of the hearing. Not just any nurse can work in behavioral health wards, and social workers to protect children and manage behavioral health patients have very different tasks. Nurses in a cardiac unit do not have to provide group therapy 3 times a day. Without a massive infusion of public funding, it is hard to create behavioral health beds, which will require dedicated staff in more than one meaning and facilities that can only be used for behavioral health. In the current environment, getting a treatment bed is not easy unless you are in custody, of course. Behavioral health care is ultimately custodial care in the early stages. They just won't let you out to begin with. Patients sometimes need more intense care after initial care. Once one is discharged, it is almost impossible to get back in, especially for medication management. Changing medications can be unpredictable and painful. Patients should have the ability to do this in a safer space than a shelter or even in subsidized housing or at home, with family around. Likewise, it takes a long time to be able to cope with medication management from the patient perspective. And even then, it is sometimes hard to get on the right meds with minimal side effects. There's other kinds of meds to take, that help the digestion go, and that aid indigestion, that, it takes time to be used to doing that. Senecot is one of those things that has to be on anybody's shelf. Hypomanic bipolar 2 patients have it harder, mostly because what is needed by bipolar 1 patients in terms of antipsychotic medication is not needed for them, yet it's still prescribed. Sometimes it's just prescribed for sleep, and insomnia is a concern for bipolar 2 patients, but may be better managed with other treatments like hydroxyzine, and melatonin. Patient education through pediatric rehabilitation programs are a valuable resource, but the supply is nowhere near the demand. This is a place for integration too. If as a hospital gets you into a PRP, that would be a good thing. But people are in a hurry to get people out without necessarily doing that step. And not everybody has a PRP. While some patients will never work again if their issues are disabling, others need PRPs as a form of workforce development or redevelopment, actually. Let me quote from testimony from the June 2021 hearing before the committee. For workforce development and general recovery, psychiatric rehabilitation programs such as the Center for Behavioral Health in Rockville and Cornerstone, Montgomery, and Gaithersburg are essential. To make them more attractive and increase our ability to manage, especially in the period before disability programs kick in, participation should be paid at the minimum wage. People will participate in this care more frequently if their opportunity costs are met. Those with less than a full education should receive that education through the public and private providers and again be paid to do so. Healthcare currently provided through Medicare should be dual eligible, or Medicaid should be dual eligible for everyone. We call that, of course, Build Back Better. Or not Build Back Better, excuse me. Medicare for all, yes. And this should be regardless for income, and before Medicare reform goes in through a public option. A public option is another way to make sure people get care, and it should be at little or no cost. Instead of using a larger system, clients should have the option of receiving coverage through the PRP's employee plan. What I mean there is that the PRP will offer psychiatric care, but for other medical care, instead of having an integrated system through the government, you go the other way and have the treat clients as employees for the purposes of other health insurance. The cost would be paid by the government, but anything to get people the best health care possible. And sometimes, and of course in a single payer that won't matter. So, but we'll be talking about that next week, the EHHS budget submission to the president's budget. Now, in the old days, behavioral health patients were locked into asylums. Now we are often locked in jails, again, as discussed in the attachment. We burden relatives or live on the street. Society has been penny wise and pound foolish. Society cannot work for merely parity. Behavioral health patients need special attention, and the system needs a large influx of resources, both physical infrastructure, housing for disabled and partially disabled clients, and trained personnel. The latter requires its own set of incentives, including willing workers. People have to want to do this. It's not everybody who can. One way to free up case management resources is to move them from other social services. Having higher minimum wages and paid ESL, remedial education, technical or associate's degree level training, and much higher child tax credits will take many clients out of the anti-poverty sector. Signing up for programs like TANF needs to be replaced with enrollment in a training program with easy entry and pay, again, to meet the client's opportunity costs, as we just said. This will free up an army of social workers who might be interested in more client contact and less paper shuffling. and of course a little developmental education if they want to get that master's in social work if they don't have it. It's harder work, but more satisfying, especially if funded correctly. So it's everything can be improved. Thank you very much for your time and attention. I've also in the comments, or there's an attachment for mental health care from last February's Ways and Means Committee, and a video for part one of that test of those comments. They're more applicable. They're better organized to go with this piece. Veterans health care and other issues are in part two for that hearing. So this should meet your needs. I thank you very much for your time again. Have a pleasant day.